the caregiver becomes hypervigilant to the needs of the patient, and that often then is related to really poor self-care. Now, one interest for me, particularly in lung cancer, is that the spouses oftentimes have their own comorbidities. They have their medical issues as they are, later in life. The mean age is around 60, mid-60s. So they have their own medical problems, and from our other research, we know that they oftentimes neglect their own medical care while taking care of the patient. So with the work that we're doing, with the interventions that we're doing, is we really try to get for the caregiver also take care of his or her own medical, appointments, self-care, and really open the communications of relating to each other as as husband and wife, or as partners, as opposed to patient and caregiver, where the flow of support is very one-sided. So our interventions focus on patient and caregiver relating to each other in a team approach, and also making sure that the voice of the caregiver, of the spouse, is heard, and that the spouse receives support. Now, to what extent the patient may tangibly support the spouse, that's of course limited based on their physical well-being. But what we know is that emotional support, listening, being there, expressing love, affection, and care is the most important source of support anyway. So, and regardless of the condition, most patients can do that and want to do that. So they need to be given an opportunity. And also that what we think and what we're trying to figure out is that putting patients in this active role, as opposed to just being the recipient of support, it may actually help them and empower them and give them a sense of purpose and meaning, that they are not helpless, and they still contribute to the relationship in an important manner.